Recording in
Well, good morning, everybody. Thank you for joining us. As some of you might know, I'm Tony from Mercy Family Medicine residency program in Perrysburg. We're at Lighthouse Way. And as we do the third Wednesday of each month, give a talk on a different medical topic. Today we have Dr. Greenberg with us, who's going to talk about stroke risk in older adults. Certainly as we get older, we worry about a lot of different things. And one of the things that probably comes to the front of our minds is the possibility of having a stroke, because we've either had a stroke ourselves or we know somebody that had a stroke, and we know some of those can have minimal effects and people recover nicely from them. But sometimes people have strokes that are a little bit more severe and carry deficits with those, so they're unable to do certain things. So today, Dr. Greenberg's going to talk a little bit about stroke in general. There's different kinds of strokes, so to know the difference between them, some of the factors that cause stroke, some of the things that we can do to prevent a stroke. There's what we call modifiable and non-modifiable factors. So modifiable are those things we can change. Non-modifiable are the things we can't. He'll talk about those. And then probably one of the other very important things is how to recognize a stroke, not just about ourselves, but if we are here at the senior center and we're used to seeing, somebody and we're like, well, they're not exactly acting themselves today, to kind of be aware of some of the signs and symptoms. So I'm going to turn it over to him, and we'll stick around in case you have any personal questions.
All right. So we'll start off with what a stroke is, and then there's two different types of stroke. One is the mini stroke. I'll work kind of backwards. Mini stroke, also called a transient ischemic attack. This usually happens and passes and you're back to normal. There's no evidence of anything happening, so you can't test really. Well, you'll test for it, but you won't see anything. And then there's ischemic stroke, where there's a lack of blood flow to a certain part of the brain. You'll have whatever part of the brain is affected, different deficits. So it's facial drooping, speech problems, weakness somewhere. And then same with hemorrhagic stroke, you'll have a deficit where there's a brain bleed, compressing that part of the brain. So why is it important to talk about stroke? Because it's the fifth leading cause death and disability in the United States. 70% of people that have a stroke are older than age 65. So that's why we try to target people older than 65. Yeah, so that's what a stroke is. Then there's some risk factors. Like Tony said, there's modifiable and unmodifiable risk factors. Non-modifiable is things you can't change: age, sex, gender, race and ethnicity. So usually males, elderly, at some point over the age of 85, then it becomes about equal, where men and women are equally as likely to have a stroke. But then in African American men, that's the most high risk. Modifiable risk factors. So these are things we can change. Usually there are some comorbid conditions, so high blood pressure, obesity, a sedentary lifestyle, diet, poor diet, any type of heart disease, heart failure, atrial fibrillation, diabetes, high blood pressure, high cholesterol. Those are all modifiable risk factors. So when you're talking with your doctor and they mention, oh, you have high blood pressure, you're like, it's not that high. It's like, well, we don't want it to damage the blood vessels and cause issues later on. So we're trying to prevent further injury down the line. So that's why we bring it up. Is, well, yeah, it's not that high, but we don't want anything bad to happen. We're just trying to protect you. So same with high cholesterol, and diabetes. A lot of them are asymptomatic until something happens. So you might be like, oh, well, I have high cholesterol, but I feel fine. Okay. but we're just trying to, again, we're trying to protect you and being put on a medication that helps with, you're good, helps with, all these different diseases can help with stroke, which is what we're trying to do. Physical activity, um, they say having a more like about recommendations about 150 minutes of activity per day, per week. Divide that however you want for up throughout the week can help. And then low sodium diet, Mediterranean diets, what people tend to benefit the most from. Smoking is the number one cause of pretty much everything. So don't smoke. If you are smoking, you can always talk with your doctor about counseling and methods to try to stop smoking. So yeah, those are the risk factors. Symptoms of a stroke, you might notice this in yourself, or you might notice it in someone else. There's an acronym called BFAST. Each one stands for something else. The B stands for some sort of balance issue. Usually it's sudden, and not like over time it'll happen. You can notice it within, they're walking normally and then all of a sudden they're not. Eyes, they can have double vision, blurred vision. F is for facial drooping, so they'll have like they can't make a smile, or there'll be some sort of asymmetry in their face where one side looks different than the other. A is for arm weakness. I would say not because of the acronym. A goes with arm, but any sort of extremity weakness would indicate things going on. And then speech difficulties. Usually it can be two different types. One will be where they're talking and then all of a sudden it's not making any sense. Or they're talking and then all of a sudden they cannot form words. They know what they want to say. They might be able to write it down, but they can't say it. And that's once again going back to the different types of strokes. If it's affecting different parts of the brain, they might present with different symptoms. And then the T is just calling how quickly you're calling 911, and getting the person that's being affected help. So that's some of the symptoms of stroke, and just a quick acronym to try to navigate the situation. Now, if you're noticing someone might be having a stroke, similar acronym is the FAST acronym. So you can ask them to smile to see if there's any facial asymmetry, ask them to raise their arms, ask them to say something to see if there's any slurred speech, and then again, calling 911. Noting when you're going to have, when the last known time they were themselves is very important and helpful for whoever's taking care of them, because time is of the essence in a stroke. The faster you go, the more likely you can have better recovery. And then CPR, depending on what's going on in the situation, you might have somebody come do CPR, or you may be the one doing it. But some of the things not to do when someone might be having a stroke is telling them to sleep it off, or just take their medications and wait it out. Like I said, the quicker you're getting active health, the more likelihood you'll have a better recovery. So in calling EMS to transport whoever it is would be the best option, unless you can safely drive them somewhere. Yeah, so that's what not to do. And then similar to what I talked about earlier with the modifiable risk factors, some of the ways we can minimize risk is getting our screenings done. Any of the bad habits that we have, whether it's poor diet, not having a sedentary lifestyle, smoking, any of those things, taking care of those would help. And then, like I said earlier, any of the comorbid conditions, getting those under control and preventing further disease and damage would benefit us. So, yeah, that's pretty much it. If you have any questions, I'll take any questions.
I always wondered when it stops, and you don't want it to start to make it stop.
Right. Stop smoking, do not smoke, I should say.
The other thing I'll say, and this, every time we give this talk, I don't know, every couple of 3 years, and it always reminds me, if you are in a position down the road that you have to wear some type of life alert, either the necklace or now they have the watches and everything. Please have that with you at all times. About 35 years ago, one of the very first patients I ever saw in the hospital was a lady. She was, I don't know, close to 85. And I went in that Monday morning and I asked her how she was doing. And she says, let me tell you, honey, I wear a life alert. And I was laying in bed and I toss and turn. So it goes this way and it goes this way. And I got tired of it. So I took it off and I put it on my nightstand while I had to go to the bathroom during the night. And that's when I had a stroke, and she sat on that toilet with a stroke for 24 hours. And she said, I have never been so happy in all my life to see 4 men find me sitting on a toilet. It's, again, so many years later, decades later, it just reminds me of that story. So you never know when it's going to happen. So I always say, just make sure that you're constantly vigilant about things.
Do you usually have any type of pain or anything like that to give you a warning other than those other signs?
Maybe, I mean, it depends on what's being affected. Usually it's not so much pain. It's more of just some sort of weakness or. But you might have pain, it depends on where it is.
I just wondered because my mother had an aneurysm of the brain,
Right.
and we never knew whether it was caused from a stroke or whether, she had any pain before that or any, she never said. And by the time they got her to the hospital, it's too late to, ask her things, so.
I mean, that's a good question. I think about all the patients I ever saw. When I worked in the emergency room that came in stroke wise, I don't ever recall any of them having significant pain. Even the ones that had the hemorrhagic stroke that he talked about earlier, the brain bleed, as traumatic as that is, I think their body goes into like a shock, exactly.
So the most. Say it,
Most common
common,
symptoms.
thank you, would be the speaking or
Yeah, most,
difficulty in memory and.
yeah, memory, any weakness. And it might not be weakness, like, oh, I feel fine, I can move, but you're not, like, something's off with how they're moving.
Okay.
And then some other diseases kind of overlap. So like a brain bleed, maybe they fell and hit their head and that's why they're bleeding, or they had an aneurysm ruptured and that's why they're bleeding. So and then smoking can increase your risk for aneurysm. So then it's, yeah, I mean, they call high blood pressure the silent killer because you don't have typically no symptoms until you have a stroke. So.
And there a little bit further back on this handout, there was also the important thing is don't ever let somebody talk you out of calling 911. I mean, do what's right and do what's right the first time, because as he mentioned before, time is of the essence. And particularly men get stubborn, or a family member gets stubborn because they say, I'm fine, I'll be better in a couple of minutes. And, so don't ever hesitate to err on the side of caution and doing it.
The other question I have, it says perform CPR. If they're breathing normally and everything, you still perform the CPR?
No, if necessary. So,
Oh, I see.
yeah. So like if they have a stroke in a part of the brain that controls breathing and the heart rate, that would be.
Okay. I see what you're saying. That would change over time. I remember taking Red Cross training
Yeah.
with my youngest daughter with
anxious to learn it when she was in high school. So I went with.
Yeah.
And then the first renewal, they, you know, she was having dreams that somebody needed it and we hadn't had the renewal training. And, you know, and I was giving her nightmares, right? So we did it again, but I haven't done it since. I'm not sure that I know enough to do it now. I can remember what the check, I mean, this is,
Yeah,
you know,
yes, I don't know when.
Yeah, I mean, even when I was first taught in the army, you know, you did a lot of mouth-to-mouth resuscitation and things like that. Things we've kind of shied away from. It's just more chest compressions and some of the music they have you think about doing the chest compressions too. Things haven't changed a great deal. They've just been altered slightly. You won't be faulted for doing what you know,
Yeah,
but a lot of that's still the same.
Good Samaritan law will protect us,
Maybe that would be a good class to show.
the CPR.
Could be.
I mean, you know.
Yeah. Because if that class is gonna be done, I'd like to see somebody like the Red Cross come in
Right.
and do it from a certified standpoint. Because a lot of times. While the resident physicians are trained, they're doing it spur of the moment, you know, either
Gotcha.
in the hospital or something, and they've got a lot more equipment around to kind of help their cause.
Sure.
I'd rather have somebody like that come in and do it, but great question.
my kneeler.
And in my case, I might need somebody to help me get back up, so. Oh, yeah, absolutely. Yeah, they always have. Yeah.
Right, because it's nice to know, and I could get down and be fine, and might be able to get. But it wouldn't matter, somebody else can be there, and they help,
Right.
whatever. I'll look online.
Well, thank you all for attending. I appreciate your time. I was standing here trying to think of what next month's topic is, and I apologize. Heat stroke, and you get me, so, all right, prepare yourself. I'm giving you 4 weeks advance notice. So in the meantime, have a good month, safe month, and take care. Thanks for joining us.
Thank you.
Sorry, when you said that. The buzzer is not eyes, well, hey, how much is too hot that it really might.
Sharon, I just saw your message
Yeah.
here, so we can ask them and I'll get you an answer, okay?
I know, and that's.
You can answer it. She said, how is the skin? Murad.
Had a doctor prescription.
Strokes differentiated, so the appropriate treatment can be
That
done.
was an FD,
I'm gonna let him answer that.
Iowa Medical Clinic, because my husband was a student and